morning, one and all. Here we are going to discuss the suppurative and non-suppurative complications of Streptococcus pyogenes. As an introduction, Streptococci are a group of bacteria that comes under the family Streptococcaceae. They are gram-positive, occurs in paints or chains, and are catalase negative. The species that comes under Streptococcus are mainly Streptococcus pyogenes, which causes pyogenic infections. Streptococcus agalactiae causes meningitis in newborn. Streptococcus pneumoniae causes pneumonia and meningitis. Based on the classification, we can divide this into hemolytic, then aerobic facultative and obligative anaerobic. Based on Blanchfield grouping, Griffith typing, genotyping, we can classify this Streptococci into many types. So in this context, we are going to discuss about Streptococcus pyogenes. So this Streptococcus pyogenes are the only species under Blanchfield group A Streptococcus. Otherwise, we can call them simply GAS. These are gram-positive, occurs in pairs or chains, and are catalase negative. Streptococcus pyogenes causes pyogenic infections, including suppurative infections and post-infectious non-suppurative complications. Next, we are going to discuss about the virulence factors of Streptococcus pyogenes. First one is cell wall antigens, then toxins and enzymes. So this is the structure showing the virulence factors of Streptococcus pyogenes. Primary important virulence factor is cell wall antigens, in that peptidoglycan layer, which induces inflammatory response and thrombolytic activity. Then middle layer of group specific C carbohydrate antigen. Outer layer of protein and lipoic acid consists of MTR antigens. This helps in adhesion. Other cell wall proteins include M-associated protein, hair-like fimbriae, F factor. The Streptococcus pyogenes possess capsule, which is antiphagocytic and helps in the colonization of bacteria to pharynx by binding to CD44 receptors. So in this figure, we can see the peptidoglycan layer, middle layer of group-specific carbohydrate antigen, outer layer of proteins and lipoic acid. Cell wall is there, cytoplasm, cytoplasmic membrane is there, and M protein. So next, we are going to discuss about the toxins. The toxins mainly include hemolysins. Hemolysins, these are completely beta hemolytic organisms, and they show complete beta hemolytic zone surrounding the colonies. Next is streptococcal pyrogenic exotoxin. This is otherwise called SPE toxin. These are pyrogenic, that is responsible for fever. These are responsible for scarlet fever, necrotizing fasciitis, and toxic shock syndrome. Next, we are going to discuss about the enzymes. What are the enzymes responsible for the pathogenesis? The primary important one is streptokinase, otherwise called fibrinolysin, which facilitate the spread of infection. Streptodonase or DNase are responsible for serous nature of streptococcal exudate. Other enzymes include hyaluronidase, which is a spreading factor which helps in the spreading of this organism. NADase, which is antigenic and leukotoxic. Next is serum opacity factor. In that, there is SPY-CEP, which is a neutrophil chemoattractant. C5a peptidase, it's also a neutrophil chemoattractant. Then other enzymes involve neuraminidase, N-acetyl glucosaminidase, esterase, and phosphatase. So these are the main virulence factors of Streptococcus pyogenes. So the main important virulence factor is cell wall antigen. In that, peptidoglycan layer is there, C carbohydrate antigen is there, then protein and lipoic acid, M associated protein or M protein, which is the principal virulence factor of group A Streptococcus. This M protein inhibits phagocytosis, which will bind to fibrinogen, together bind to beta-2 integrins of neutrophils, causing the release of inflammatory mediators, inducing vascular leakage, causing streptococcal toxic shock syndrome. So this M-associated protein or M protein is the principal virulence factor of group A streptococci. Then next comes the capsule, that is antiphagocytic, helps in the colonization of pharynx by binding to CD44 receptors. Then toxins. In toxins, there are hemolysins and streptococcal pyrogenic exotoxin. And enzymes, which include streptokinase, streptodonase, hyaluronidase, NADase, then C5a peptidase, SPYCEP, that is serum opacity factor, the neuraminidase, N-acetyl glucosaminidase, esterase, and phosphatase. So, next comes the clinical manifestation that we are going to discuss in detail. Clinical manifestation of Streptococcus pyogenes. This include suppurative and non-suppurative manifestations. Suppurative manifestations, in that the primary one is respiratory infections. So in respiratory infection, the throat is the primary site of invasion by group A Streptococci, and mode of transmission is through respiratory droplets. The primary clinical manifestation of the Streptococcus pyogen is pharyngitis or sore throat, mainly localized, that is tonsillitis, or diffused, that is pharyngitis. Erythema and swelling of pharyngeal mucosa, purulent exudate formation. In younger children, fever, malaise, lymphadenopathy without exudative pharyngitis, and infection can spread by hematogenous or lymphatic route. And the complications include sinusitis, otitis media, meningitis, bacteremia, and post-viral pneumonia. The second clinical manifestation which comes under suppurative complication is scarlet fever. So the scarlet fever is caused by streptococcal toxin, that is streptococcal pyrogenic exotoxin ABC. And scarlet fever is characterized by pharyngitis with characteristic rash, which gives a sandpaper feel due to circulating toxins. Other manifestations which comes under scarlet fever include strawberry tongue, which shows enlarged papillae on tongue, and Pastia's line shows us rashes in skin folds. So next is skin and soft tissue infections. So under respiratory infections, the primary one is pharyngitis and the second one is scarlet fever. Next is skin and soft tissue infection. In that, first we will discuss about impetigo, otherwise called pyoderma. It's a superficial infection of skin by group A Streptococci. Common sites of infection include face, mainly nose, mouth, legs, and the lesions are painless and has no fever. Or these lesions, it is not pyrogenic, that is no fever is there in this condition. Risk factors are young children, warmer months, poor hygiene, and minor trauma. In impetigo, individual lesions will develop into red papules, later develop into vesicles, later to pustular lesions, breaks down and coalesce to form thin, papery, honeycomb-like crust. Next manifestation that comes under skin and soft tissue infection is cellulitis. Cellulitis, it is the infection involving skin and subcutaneous tissue. The next manifestation is erysipelas. It's a form of cellulitis. Areas include face and lower extremities. tender, bright, red, swollen, and indurated pewdy orange texture of skin occurs due to lymphatic obstruction. Fever and chills are there. Then superficial blebs and bullae may form later. So these are the skin and soft tissue infections, that is impetigo, cellulitis, erysipelas. Next, we will discuss about deep soft tissue infections. Deep soft tissue infections, these are infections that invade muscles and involve deep or superficial fascia. First infection that comes under deep soft tissue infection is necrotizing fasciitis, otherwise called hemolytic streptococcal gangrene. This is due to traumatized skin and gastrointestinal tract breach. The infection is acute and is rapid. Necrotizing fasciitis is characterized by severe pain with minimal erythema, malaise, fever, chills, and toxic appearance. As the disease progresses, the skin becomes dusky, develops mottled erythema, and anesthetized, lead to extensive necrosis of subcutaneous tissue, fascia, and muscles. So this group A Streptococcus is otherwise called flesh-eating bacteria. So the next clinical manifestation that comes under suppurative complication is toxic shock syndrome. This is also caused by group A Streptococcus producing pyrogenic exotoxins. These are secondary to necrotizing fasciitis or soft tissue infection. This produces shock and multi-system organ failure. Streptococcal toxic shock syndrome are bacteremic in contrast to staphylococcal toxic shock syndrome. Next clinical manifestation under the suppurative complication is bacteremia. It also occurs secondary to necrotizing fasciitis, lead to focal infections like endocarditis, meningitis, septic arthritis, osteomyelitis, toxic shock syndrome. And the last complication that comes under suppurative complications is puerperal sepsis. This is associated with infectious complications of childbirth, endometritis, and bacteremia. These are the suppurative complications of Streptococcus pyogenes. So once more, clinical manifestations of Streptococcus pyogenes can be classified into suppurative and non-suppurative. Under suppurative, there are respiratory infections, skin and soft tissue infection, deep soft tissue infections, toxic shock syndrome, bacteremia, and puerperal sepsis. Under respiratory infections, there are two types, that is pharyngitis and scarlet fever. Then skin and soft tissue infections. Under skin and soft tissue infection, the first one is impetigo, second one is cellulitis, and the third one is erysipelas. Next comes the deep soft tissue infection. In that, there is necrotizing fasciitis, otherwise called hemolytic streptococcal gangrene. Next is toxic shock syndrome, bacteremia, and puerperal sepsis. This is all about suppurative complications of group A Streptococcus. Next, we are going to discuss the non-suppurative complications of Streptococcus pyogenes. So non-suppurative complications are mainly due to antigenic cross-reactivity. So antibodies are produced against previous streptococcal infection, and they will cross-react with human tissues to produce lesions. That is, the streptococcal antigens shows molecular mimicry with human antigens. Non-suppurative complications of Streptococcus pyogenes include acute rheumatic fever, post-streptococcal glomerulonephritis, guttate psoriasis, reactive arthritis, then pediatric autoimmune neuropsychiatric disorder associated with Streptococcus pyogenes, otherwise called PANDAS. So in non-suppurative complications, we are giving more stress to acute rheumatic fever and post-streptococcal glomerular nephritis. So acute rheumatic fever, this is caused when it is previously infected with streptococcal sore throat. So here there are two theories which explains this acute rheumatic fever, that is autoimmune theory and cytotoxic theory. Under autoimmune theory, the streptococcal antibody cross-react with human tissue antigen in heart and joints. And in cytotoxic theory, toxins or enzymes, these are produced by the bacteria which cause cytotoxicity for cardiac tissue. Clinical manifestations include, it affects heart, joints, skin, and brain. Cardiac lesions include degeneration of heart valves and formation of inflammatory myocardial lesions, otherwise called Aschoff nodules. So in short, Aschoff nodules are associated with acute rheumatic fever. Long-term penicillin prophylaxis is recommended, and ASO titer is very high in this case of acute rheumatic fever. So this is the first non-suppurative complication we have discussed, that is acute rheumatic fever. This mainly occurs when the person or patient is previously infected with streptococcal sore throat. Next, we are going to discuss post-streptococcal glomerulonephritis. This occurs secondary to pyoderma or pharyngitis, rarely. This occurs due to the lodging of antigen-antibody complex on glomerular basement membrane followed by complement activation. Results in urine retention and renal insufficiency, leading to edema, hypertension, hematuria, and proteinuria. So these are all about the clinical manifestations of Streptococcus pyogens. So once again, we will repeat. The clinical manifestations of streptococcal pyogens can be divided into two, suppurative and non-suppurative complications. Under suppurative complications, first one is respiratory infection. So under respiratory infections, the primary one is pharyngitis. During respiratory infection, throat is the primary site and mode of transmission is through respiratory droplets. The primary respiratory infection is pharyngitis. It may be localized or diffused. Erythema and swelling of pharyngeal mucosa, purulent exudate formation is there. So next we had discussed scarlet fever. It is characterized by pharyngitis with characteristic rash. The two manifestations under this is strawberry tongue and Pastia's line. Next we had discussed skin and soft tissue infection. Under that we had discussed impetigo, cellulitis and erysipelas. Next is deep soft tissue infection, which invades muscles and involvement of deep or superficial fascia. Under that, we had discussed necrotizing fasciitis. Later, toxic shock syndrome, bacteremia, and perpural sepsis. Next is non-suppurative complications. These are mainly due to antigenic cross-reactivity. Streptococcal antigens have molecular mimicry with human antigens. And the non-suppurative complications include acute rheumatic fever, post-streptococcal glomerulonephritis, guttate psoriasis, reactive arthritis, and PANDAS. In that, we had discussed acute rheumatic fever. So what are the two theories? That is autoimmune theory and cytotoxic theory. Then clinical manifestations of acute rheumatic fever. Then we had discussed post-streptococcal glomerulonephritis. So these are all about the clinical manifestations of Streptococcus pyogens. Hope you understand. Thank you.